so I'm Barbara, and then this is my sidekick Ruth. So we're respiratory nurses at the Children's Hospital in Belfast. It's a regional role, so there's just the two of us do our job in Northern Ireland. So today we're going to talk about long-term ventilation and troubleshooting issues. So if we look at numbers and how home ventilation has evolved, if we look at the population in Northern Ireland, so back in 1998, there were 4 patients who required home ventilation, aged between 0 and 18 years of age. When I took up post in 2010 with 27 patients, but currently to date we've now got well over 230. Numbers just keep rising for up every month. So the children who require home ventilation, there's 3 different ways to administer either CPAP or BiPAP. So children on long-term ventilation, they are mostly children with tracheostomy tubes. So we've got 50 throughout the province of Northern Ireland, and about half of those require ventilation through their tracheostomy tube. The bulk of our patients who require ventilation would be through non-invasive mask, which we'll talk about just shortly. And then we've currently started to set up mouthpiece ventilation. So that would be for children, for instance, who need BiPAP during the night, and then if they're going to school, so say a teenager with Duchenne muscular dystrophy, if they feel they need a bit of ventilatory support at school, or if they're out and about but don't want to be stuck with a mask, they use mouthpiece, or we call it sip ventilation, where they literally would just rotate their head over and give it a sip through a straw. So we're just beginning to set that resource up.
Okay, so moving on to the tracheostomy tubes. So we have 3 tubes that we would be currently using throughout Northern Ireland. Usually when a child first gets a tracheostomy by the ENT surgeons, the tracheostomy trache tube would be the first tube of choice. And then following that first change after about a week, we usually move on to a bivona tracheostomy tube. And it probably is really the tube of choice across the region. Another tube that is becoming more popular, especially within our older children and our teenagers, and is used mostly in adults, is the Tracheostomy twist trache tube. Okay, so the Shiley tubes, they are, as I say, they're first usually used as soon as a child gets a tracheostomy tube. And reasons being is they're made of PVC plastic, so they're a very rigid tube. They would be a weekly tube change. They're single use and then thrown out. They're available in a paediatric and neonatal size, and do come in a cuffed and uncuffed tube. Okay, so following that first tube change by ENT surgeons, as we say, we usually then move on to our bivona tube. And this would be known as a more comfortable tracheostomy tube, as it is a siliconized PVC. It is changed every 28 days, so again, a bit more comfortable for the child. It is now MRI compatible as well.
So what that means, if a child is going for, say, an MRI of their tummy or their leg, it's okay to use a bivona tube. But because it's made with metal, if you were going for an MRI of, say, your airway or your head, it could potentially cause a fuzzy image. So for that actual area, we would recommend going back to the Shiley or the plastic tube.
And like the Shiley tube, it's available in paediatric and neonatal sizes. But the benefit of a bivona tube as well, that it comes in, we have the standard form, which is quite similar to the same way the Shiley's made. But we also have a flex stand bivona as well. So the benefit of that is that it's used for our children on ventilation. And the added benefit, the outside bit is very flexible. So rather than the circuit pulling on the trachea from the inside, there's a bit more pressure on the outside, reducing any chance of trauma. It is also available in a cuffed TTS, which is tight to shaft tube as well. We currently don't have very many children using cuffed tubes. We tend to, I think out of our numbers, we have about 2 children with cuffed trache tubes in the community, but it would be more common to have the cuffs the tubes cuffed in the intensive care environment if needed for ventilation pressures. With our Bivona tube as well, in all of the boxes will come a disconnection wedge, a really vital bit of equipment to have in our trachea box in case there's problems detaching our circuit. So we just use that like a wedge action to release the circuit for suctioning if needed. And finally then, again, as we were saying, the tracheo twist is used, again, more commonly in adults, but we're seeing it more and more used with our teenage group of children. So it is a polyurethane plastic. There's a swivel neck plate, again, for added comfort and maximum mobility. The benefit and difference with this and the Shiley and Bivona tube is that it consists of an inner tube and the outer tube. It is durable and suitable for long-term use. These tubes also come in fenestrated style, which again is used quite commonly in adults to enable speech. Again, we do not use this very often in children. We have about one child using a fenestrated tube within the community, but we just have to be very mindful when they come into the intensive care environment that the fenestrated tube would be changed to non-fenestrated for ventilation purposes.
So every child who has a tracheostomy tube, but we use the National Tracheostomy Safety Project, which is a really useful online resource. So there should be a bed head sign at the end of each bed and within the box, which we'll talk about in the next slide. So basically it clearly states what is the patient's name, what type of tube do they have, is it cuffed, is it uncuffed, what size of suction catheter do you need, how far should you suction, and suction length is ideally just the length of the actual tube itself. And also, are there any upper airway abnormalities? So if there is an emergency situation by the bedside, it's clearly visible for all. So that is our hospital policy. And the emergency box is literally, as it says, anything that happens in an emergency is in that box. It's always a blue box. Unlike our asthmatic children out there who forget to carry their inhalers, all our trachea patients always carry the box. So in the box we have the tube, which is the same brand and the same size. A size smaller if there's a difficult tube change, so we use the Shiley because it's more rigid, and then we have scissors, lubricating gels, suction catheters, ribbon ties, Velcro ties, and the wedge, which we've talked about. In paediatrics over in Northern Ireland, we use ribbon ties purely for a safety reason, because up until about 10 years ago we had what was Velcro ties, which basically are easy, and then the Velcro tie would go in there. But there was a few incidents over in England where the actual Velcro was acting like a cheese wire and then actually cut the flange. Trachea became dislodged and there were a couple of fatalities. So as a result, that's the reason why we use it. Also, if you've got a toddler running around with Velcro, they could easily come out and do yoo-hoo mummy and get attention. So it's safety from that point of view. We do keep the Velcro in the emergency box purely if you're on your own, because it's a one-person technique until second person should arrive to assist. So this slide shows granulation, which is a common issue that we would see for any child who has a foreign body inserted. So you can clearly see around this tracheostomy tube that there's granulation or proud skin. It can appear overnight, it can appear within an hour, but when we see it, we act upon it. Because if granulation is growing on the outside, it can equally grow on the inside and then prove a difficult tube change. So our first line of treatment that we would use is Maxitrol, which is an eye ointment, which has an antibiotic and a steroid. So the combination of the two helps to usually resolve, and we would usually prescribe it BD for about 10 days. If we know it's on the outside, then to prevent it from happening on the inside, if we're changing the tube, we would lubricate the tube, the tip of the trachea tube to help alleviate that. And since actually we've been using that, very rarely do we ever need to use silver nitrate, or children need to go to theatre to get the granulation removed. So if we look at some troubleshooting with tracheostomy, say we have a child on the ward and they're just a wee bit off form, their oxygen saturations have fallen down, there's increased work of breathing, changes in their Pew scores, skin color isn't good, and you're thinking there's something going on here. Is there an infection going on, or what actually is going on? Are the secretions green, white, thick, copious? So our first thing to do would be to suction the tracheostomy tube. And if we find then that we've cleared it, that's great. But if secretions are a bit thicker, then we would often just recommend saline nebs. We have stopped really as routine practice using saline suction and just really fine saline nebs, or if it's a bit more stickier than normal, hypertonic nebs to help clear secretions. But failing that, you have to remember in pediatrics, the tubes are just so small. So you could have what's known as a partial obstruction, where half of the tube is blocked, but then that airway is just so tiny for the child to breathe that it's causing these other symptoms, or then a total obstruction where you can't get the suction catheter down. So our rule of thumb is if you've got the Shiley or Bufona range, we just say, if in doubt, whip it out, clearly as no one will ever get into trouble for changing a tube, so it's better to err on the side of caution. Or if you've got the Tracheo twist range for the bigger child, you then just need to change the inner cannula, take it out, place a new one in, and that should hopefully resolve the issue.
Okay, so once we've established that we're dealing with the blocked trachea, along with our bed head, we also have our emergency tracheostomy algorithm. So it's good to have a member of staff potentially reading this out in an emergency situation. Our first line really is with our emergency box. As we've mentioned before, the first change is our same size, same brand tube. Okay, we get that change done, all's okay, that's good. But we say it isn't, so we've had difficulty inserting the same size, same brand. So we, again, our emergency box, we go for our Shiley, and we remember that we said our Shiley's a more rigid tube, so and it's a size smaller, so we're trying our Shiley. Again, we get it in. All's good. We want to let ENT know that there has been a difficult tube change and that the child now has a Shiley tracheostomy tube in place. And then the other side of things is we haven't been able to get that smaller tube in. So we're then looking at going to the Sledgener technique, where we're going to still use our smaller Shiley tracheostomy tube, and we're going to get our suction catheter, have our introducer out of the Shiley tube, and we're going to place our suction catheter slightly through our tube in the hope that we can insert the suction tube in through the stoma and then glide over our tracheostomy tube and then remove our suction catheter. Again, all good. We need to inform ENT of the difficult tube change. If things haven't gone successfully, we're looking at a BLS scenario where we're probably having to cover our trachea, as we have no secure airway, so we're covering our tracheostomy stoma and we're providing breaths via the mouth and nose. I think in my whole career, and I've been working a very long time, as you can tell by my face, I've had just one episode where I haven't been able to get a tube in. Years ago, we used to keep trachedilators by the bedside. We don't use that as routine practice in case it causes more trauma. So this situation was a 2-year-old, and she was due a tube change. I couldn't get the tube in, and I knew everybody would be calling from either me or Ruth, and it was me who was by the bedside. But what actually happened was she was 2. She was having a toddler tantrum. So after about 10 seconds, which felt like about a minute, she took a big gasp in, stoma opened, and then you were clearly able to get inside. So, I mean, you just have to think always outside the box. So if we move on then to non-invasive ventilation, so the interfaces we have, again, compared to adults, we're one size fits all. We're dealing with children aged 0 to 18. So with nasal masks, full face masks, nasal pillows. So for the wee ones, we generally use nasal masks purely because in case their mummies prefer it, where they're crying out in the middle of the night for their mummy, or if they're sick, there's then the risk of aspiration. Or say you have a child with neuromuscular Duchenne, as the disease progresses and they're getting into sort of adolescence, they might feel the need, or if you're a mouth breather,
the need for full face ventilation. So again, we just review each situation as we deal with it. So then we and children who are ventilated at home have vented masks where you need to release carbon dioxide. In intensive care, there could be the other possibility of you're on the intensive care ventilator, you need a non-vented mask. So the difference between these two masks are non-vented masks have a blue connection, and vented masks either have your exhalation port, or with this brand, the Philips brand, it would be orange. If you have a situation where you're in intensive care and you've got a mask issue, you can always have the option of using an exhalation port to help release carbon dioxide. The ventilator in Northern Ireland that we use of choice for the most vulnerable children is the Trilogy Evo ventilator. And we generally try to streamline that. So if children present at their local district general hospital, that we're all able to give the support. It's a great ventilator because it gives you approximately about 8 hours battery life, and it can give you 3 or 4 profile settings, so a baseline and emergency, physio, for whatever the reasons are. And parents are given permission, if they're unwell, change to the emergency profile and then get your child seen. In this particular ventilator, they're all locked purely for safety reasons at home. And so to unlock this particular ventilator, you press the alarm button on the bottom left and the digital clock on the right to give you full access to change settings. Another bonus with this ventilator is you're able to give oxygen through the ventilator. So you're able to, so then oxygen is delivered as well, which is another added component. So really to conclude, Ruth and I, we've talked about the different types of trachea tubes, the different types of intervention or interfaces, troubleshooting issues with the trachea mask or ventilation. But really, if anything comes from this, it's we always say, always listen to the parents of the carers. They know their children inside out. When a mother's gut or a daddy's gut says, listen, I'm not happy, you do listen, because their guts generally are always right. That's us. Any questions? And thank you for listening.
I suppose one of the biggest challenges is that there's so many different types of masks, different types of ventilators, and it's impossible to be familiar with all of them. I suppose trying to standardize is ideal if you can have a sort of standard ventilator for that you're using within a particular region, but that's not always practical. I suppose it's just making people aware and having a way of access and how to change, to unlock settings and so on if need be, and knowing who to contact in an emergency situation.
The big question for me is, given how quick numbers are expanding, and certainly in Glasgow we're finding the exact same thing, where are these patients, and if they're coming into hospital, where are they going to? Are they all coming to ICU? Are they coming to HDU? Are they coming to the ward? What's your hospital's admission criteria?
Yeah, that's a good question. And actually, it's a really good question, particularly at this time of the year coming into winter. And regardless of where you reside, winter pressures come with respiratory conditions. So it really just depends. And I think one other key thing is it's in the summer we have issues. It's really hot. Mummy, I want a lollipop. Well, a child with a ventilator or a tracheostomy tube needs extra hydration. Again, coming into winter, we've got heat and different types of central heating that can affect secretions. So then in that instance, then you're increasing saline nebs. Again, if you're coming into hospital, it obviously impacts on nursing ratio. So it is a really difficult area because these children do require obviously higher forms of supervision. So you just have to really work with A, what's wrong with them, and B, how they are.
And a lot of these patients, if they come in for something else, if they come in for surgery but they happen to be trachea vented, are they going to ICU because they're trachea vented, even though parents manage those things at home?
No, they can be. It depends on what they're going for, obviously, but there's no reason why they couldn't be managed at ward level. What we generally find is within this hospital, the surgical unit feel a bit uncomfortable having tracheostomy, so then the medical units tend to deal with them. And then depending on what their ventilatory needs are, if they're on high pressures as a precaution, if it's an elective procedure, you would generally have a ICU bed booked, depending on what the procedure is. If it's just a quick look in, an MLB, then generally speaking, it could be just a day procedure. So it just really depends what the actual procedure is.
Can I ask one more?
Yeah, go for it.
What the sort of like a new patient trachea vented, what is your time frame from getting them established on a vent, all the training, ventilator support workers at home, etc., etc.? What's the time frame from decision of trachea vent to discharge?
Oh, very, 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 very good question. It can be up to a year is the reality, because care packages are just very difficult to get, and within Northern Ireland, each trust, it just really varies.
Yeah, we find it very dependent on where the child resides as to how quickly they get home.
It also depends on which trust, and you know, if district general hospitals can take them. So it's extremely challenging and very frustrating for families, because they can be not reunited as a family for up to about a year. So it's very, very frustrating.
I've seen a lot.
We recently had there one just about to be discharged home after about 5 or 6 months. But most of the majority of them tend to be working on to a year.